Hi everyone, my name is Mijun Park and I'm a current Master's of Science student at McMaster University. Today I will be presenting my systematic review and meta-analysis or rates of obstetric anal sphincter injury higher in Asian versus white individuals. Here is a quick outline of my presentation. I will go over my study's background and objective, methods, results, and end with discussion and conclusion. So let's begin. What is obstetric anal sphincter injury, also known as OASI? The aggregation of third and fourth degree perineal laceration is the established definition of OASI in Canada and internationally, adopted by the Society of Obstetricians and Gynecologists of Canada, the World Health Organization, and the International Consultation on Incontinence. OASI describes the laceration of the external anal sphincter and/or the internal anal sphincter. Third-degree lacerations involve the external anal sphincters and/or the internal anal sphincters, while fourth degree also includes lacerations of the anal mucosa. OASI can lead to chronic maternal complications, including dyspareunia, pelvic floor disorders, mental health morbidity, and incontinence. OASI occurs in 4.4 to 6% of vaginal births in Canada, and the rates of OASI in Canada are increasing in individuals having a vaginal birth for the first time. This graph shows us the temporal trends in OASI in Canada between the years 2004 and 2014, stratified by parity and obstetric history. You can see in the x-axis the year of delivery. The y-axis indicates the rate of obstetric trauma in percentage. The round markers show us the rate of OASI in individuals having a first birth. The open triangle markers show those who are having a vaginal birth for the first time after having a cesarean delivery. And we can see in both nulliparous individuals and those with a previous cesarean delivery, the rate of OASI increased over this time period. Obstetric anal sphincter injuries is an area worthy of study, particularly in Canada. This figure shows rates of OASIS with and without instrument in 24 OECD countries in 2019. The darker purple bar is without instrument and lighter is with instruments such as forceps and vacuums. Orange bar in the center of the graph shows the average of the OECD countries, 1.4 without instrument and 5.3 with instrument. As you can see on the far right, OASI in Canada is the highest among 24 OECD countries, 3.4 without instrument and 16.3 with instrument. Racial and ethnic disparities are pervasive in maternal health and represent a major source of health inequity in many settings. Studies of composite severe maternal morbidity across racial groups in Europe, Australia, and North America have shown similar trends. I will go over just a few examples that highlight this issue. We see here the graph on the left shows strong relationships between race, ethnicity, and severe maternal morbidity, even more than community-level income and hospital income in the US context. The red figure on the right shows that Black women face 3 times the maternal mortality risk as white women. And the light blue figure on the right is from the Embrace report, which is the review of maternal health in the United Kingdom, showing that Black and Asian women have a higher risk of dying in pregnancy. Despite this, we have yet to understand the relationship between race, ethnicity, and specific causes of maternal morbidity, such as obstetric trauma. Studies have found that Asian individuals living in their country of origin experience lower rates of OASI. Conversely, studies from high-income non-Asian countries have identified an increased risk of OASI in individuals who identify as Asian versus those who identify as white. We conducted a systematic review and meta-analysis to evaluate whether there is an increased prevalence of OASI in Asian versus white individuals. We searched Medline, Ovid, Embase, MCare, and the Cochrane database from 1910 to 2022 for observational studies. Keywords and controlled vocabulary terms related to race, ethnicity, and OASI were used. 2 reviewers independently screened abstracts, performed full-text assessments using Covidence. Meta-analysis was performed using RevMan version 5.4 for dichotomous data using the random effects model and the odds ratio as effect measure with a 95% confidence interval. 2,828 studies were identified through database search, which then went through screening and full text review to end with 19 studies. Now I will discuss our results. Out of 19 studies, majority originated from the US and Western Europe, as you can see in this graph. There were also various study designs included, with most being retrospective cohort. These are the results from the meta-analysis. The meta-analysis revealed increased prevalence for OASI in the Asian group with an overall odds ratio of 1.59 and a 95% confidence interval of 1.33 to 1.9. We found a high level of heterogeneity with an I-squared value of 97%. In subgroup analyses of studies reporting more detailed data on Asian ethnic group, we found the rate of OASI was highest among South Asian individuals with an overall odds ratio of 2.35 and a 95% confidence interval of 2.06 to 2.68. Heterogeneity was reduced with an I-squared value of 74%. In Chinese individuals, the overall odds ratio was 1.66 with a 95% confidence interval of 1.22 and 2.26, with an I-squared value of 69%. Only 5 out of 19 studies formally explored causal mechanisms to explain the association between Asian race and higher rates of OASI. The causal mechanisms explored were perineal body length, BMI and fetal maternal size disproportion, and language barrier. Maternal characteristics and obstetric practice factors were not found to mediate the association between race and OASI. Here are some potential causal mechanisms that were not formally explored by the 19 studies. Differential obstetric care, which would include different rates of episiotomy, duration labor, and intervention rates. Differences in Asian Western practices as well as beliefs that may lead to confusion, miscommunication, and more. And last but not least, lack of cultural competency and safety. Lack of diversity within the medical profession has been found to play a role in creating disadvantageous care experienced by Asian individuals. Several limitations were discovered within the examined literature. First and foremost, there was limited race-based data and heterogeneity within conventionally used race categories. There was inappropriate grouping and definitions of race. And last but not least, there is a lack of qualitative and mixed method study designs that would give context and live experiential data. To conclude, Asian individuals, particularly those from South Asia, have higher rates of OASI compared with white individuals. Few studies have explored underlying causal mechanisms responsible for this relationship. Qualitative and quantitative research to address this knowledge gap is warranted. I would like to thank my wonderful master's thesis supervisor and co-author, Dr. Julia M. Maraca. Thank you very much for listening. And if you have any questions, I would be happy to connect via email.